Welcome to the webinar, Enhancing National Health Financing Through Digital Technologies, Innovations and Lessons from Asia and the Pacific region. This webinar will serve as a platform for exchanging knowledge and experiences in digital health financing. We are thrilled to have you all today here. Let's kickstart the session by inviting Ms. Ayako, Senior Director, Human Social Development, Asian Development Bank. Let's hear it from her, the opening remarks, and set the tone for today's discussion. Over to you, Ms. Ayako.
Yeah, thank you very much. And good morning, good afternoon, good evening, everyone, and greeting from the Asian Development Bank. It's really with a great enthusiasm that I welcome you to this first webinar under the ADB Technical Assistance 9967, using digital technology to improve national health financing in Asia and the Pacific. This webinar titled Enhancing National Health Financing Through Digital Technologies, Innovations and Lessons from Asia and the Pacific region is a crucial step in our collective journey to leverage technology for the betterment of healthcare financing in our region. So I'm thrilled to see this big turnout today from across the globe with key stakeholders from government, development partners, and others united by a common interest in leveraging technology-driven solutions to improve and advance healthcare financing in this region. In recent years, the intersection of healthcare and technologies has really helped a wave of innovation, promising transformative changes in how we finance, access, and deliver healthcare services. So today, we delve into the dynamic landscape of digital health financing. And in this domain, creativity and collaboration hold the key to addressing long-standing challenges and unlocking the potential of new opportunities in this critical field. So through the TIE 9967 project, we have had the privilege of collaborating with government and stakeholders from the region to address key issues in digital health financing. Our work has included conducting an innovation challenge in the form of a hackathon, undertaking a baseline assessment of the digital health financing ecosystem of partner countries, and proposing innovative solutions to mitigate their ongoing and foreseen challenges. So during our time together, we will embark on a journey through a diverse range of topics, from a pivotal role of digital platform in improving healthcare financing to the emerging trends reshaping the healthcare financing landscape. So our esteemed panel of experts will not only provide insight and share experiences, but also steer discussion that I'm confident that will inspire and enlighten all of us. So let us harness the power of collective wisdom to chart a course toward a more equitable, efficient, and sustainable healthcare system. So once again, thank you for joining us. And without further ado, let's really dive into the world of digital health financing. Thank you.
So, Ms. Ayako, now moving ahead with our first session, setting the context on digitalization within health financing schemes, I invite over Dr. Akito Watabe, Health Specialist, Asian Development Bank. Over to you, Dr. Akito.
Thank you very much, Ayako and Taria. And thank you for everyone joining the webinar today. I'm leading this TIE 9967 with Jay, my colleague. So today, first of all, to set the context of this webinar, let me start with the role of digitalization in health financing schemes. Next slide, please. Can you share the slide on the screen? Okay, thank you. So next slide. Sorry, not this one, the previous one, please. Previous slide, please. Yes, thank you. So as you know, the Universalist College, its global target were updated in 2023 in September as part of the UNGA HADO meeting on USA in New York. And under the SDG target 3.8 on universalist coverage, there are two monitoring indicators to measure the progress of the UHC. The first one is 3.8.1 on service coverage, and the second one is 3.8.2 on the financial risk protection. For the SDG indicator 3.8.1 related to target, is to update it to progressively address the global shortfall of 523 million people without access to financial hardship. And also to provide the coverage for the 1 billion additional people by 2025, with a view to cover all people by 2030. And the for 3.8.2 on the financial risk protection part, to reverse the trend of rising catastrophic out-of-pocket health expenditure by providing measurable, ensure financial risk protection and eliminate impoverishment due to the health-related expenditure by 2030. Next slide, please. So unfortunately, the world is off track to making the significant progress toward UHC by 2030. The service coverage part improvement has stagnated since 2015, and the proportion of populations that face catastrophic health spending has increased over the past decade. Particularly for the Asian Pacific region, the population's financial risks has increasing significantly over the past 2 decades. More intensive work is needed for us to support developing member countries in reducing catastrophic spending through strengthening public financing scheme and also improving efficiency of health financing system in the region. Next slide, please. So while we need more public spending on health, that is obvious to reduce the out-of-pocket expenditure, but also we need to improve the efficiency of the health systems to use limited available resources to maximize our health outcomes. So there are some ways to improve efficiency in the system through digitalization, such as behavioral, clinical, or operational inefficiency. So the behavioral inefficiency, for example, to prevent sedentary lifestyle or avoid illness, smoking, substance abuse, or no adherence to medicine, and polypharmacy and doctor shopping. In the aspect of the clinical inefficiency, we need to stop the treatment variations, avoidable hospitalization and readmissions, over-prescribing, treatment errors, and defensive medicine. And also the operational efficiency, we could improve the claim processing, manual pre-approvals, individual underwriting, and the manual premium collections or data analysis. So there are many things we can do through digitalization. So today's main focus is digital health financing. So not focus more on the service delivery side, but that is the main focus of this our TA 9967, to support the country to develop and support development and adaptation of digital national health financing systems. So we have 5 outputs under this TA, and this webinar is one of the last 2 outputs on knowledge sharing and also innovative challenges. So you will see several findings that we have done as part of the preliminary assessment and the work, and country case studies and innovative solutions from the work. Next slide, please. So in the health financing policy framework, like revenue generation, pooling, purchasing, and service provision, digital transformation can improve the health financing functions, particularly for the strategic purchasing and the better service provision part. And also that there are many operational opportunities for digitalization at almost every point in the health financing or insurance value chains, such as claims, operations, care management, beneficial management, provider management, and also product design. Next slide, please. So in the digital transformation, integration of the data source is critical for more sophisticated decision making. Without strong data interoperability, there is a risk of further fragmentation, resulting in the system efficiency. So data integration from various sources of information has three benefits for better decision making in terms of describing, predicting, and also prescribing the health financing operations. So first of all, we should know what has happened by using various sources of data, such as claim data, to generate reports and also decipher insights on issues such as incidents or procedures, cost of care, and the mixed use of the primary and secondary cares. And secondly, we can understand what is going to happen by using the analytics and machine learning to predict what may occur in the future. So this includes the prediction of disease trends, utilization and management, for example. And finally, we could suggest the best source of action by using analytics to identify the scope of improvement in the historic approach versus the new course of actions. For instance, check codage for the approval against best practices to identify whether improvement can be made in proposed care plans. Next slide. So in the next 45 minutes, you will see various preliminary findings, country case studies, and innovative solutions from our work. And also you will hear some live case studies from countries in parts of the ADB's operations. So we hope that today's webinar is useful for your country work or global regional work to accelerate the UOC progress through more efficient health financing systems. Thank you very much, and over to the moderator.
Thank you, Dr. Akito, for setting up the context. Taking this forward, we have next session on digital solutions for tackling fraud, waste, and abuse in health financing schemes. And for this, I would like to invite Ms. Thalia, Managing Partner, Health Advisory, ACG, and Mr. Konark, Director, Insurance, FS Advisory, KPMG. Over to you.
Thanks very much. Delighted to be able to be here with you today to talk about this really important issue, fraud, waste and abuse in health financing systems. Perhaps I'll just begin by giving a brief overview so we're all on the same page about what we mean by fraud, waste and abuse. If we could move to the next slide, please. So fraud is probably a term that many on the call will be familiar with, and it essentially means any activity that's undertaken which is illegal. So a good example of this would be a claim that's made either by a provider or a policyholder for a service which never occurred. It's an entirely fraudulent claim. We don't have specific numbers because it's often very hard to detect within health systems, but WHO estimate that between 8 to 9% of all total health spending is a result of fraud. So a really significant issue facing health systems globally. Abuse is related to fraud, but it's slightly different in that it often doesn't meet the standard of proof that you would need for a case to be pursued as fraud. So often this can be activity which is heavily provider driven. So for example, a doctor prescribing a course of treatment, whether it's pharmaceuticals or whether it's diagnostic testing, which are entirely clinically unnecessary. The physician knows that they hold no clinical value, but nonetheless, they're recommended in order that the provider can receive funding. So we see that a lot in fee-for-service healthcare systems, although it's endemic in all health systems to some degree. Waste is the final category, and it's distinctly different from the first two in that it's wasteful spending, but it's often not the result of individuals acting with ill intent or malice. So, for example, a hospital may keep a patient in their ward for a really long period of time, not because they're trying to game the system, but because they perhaps don't have the skills or confidence to know how to manage that patient's condition well. So often it's a result of capacity or capability gaps that leads to that inefficiency in health systems. So these are really big issues. I'm sure that many on the call will have experienced them in one form or another. But what's surprising is that there's actually very little research that's been undertaken on these issues in the Asia Pacific region. And given the potential volume of fraud, waste and abuse that exists, that's quite surprising. So under this TA, next slide please, under this TA, one of the things that we sought to do was do some primary research to look at how fraud, waste and abuse was manifesting within healthcare systems. If we can move to the next slide, please. We surveyed around 237 individuals from governments, from social and commercial health insurers. And what was really surprising was that the rate of fraud, waste and abuse that individuals indicated existed within their system sat at around 30 to 40% as a median. You can see on the chart on your left. So really significant, and it's hard to think of any other sector of industry where 30 or 40% of total expenditure would just be spent on fraud, waste and abuse activity. So it's a really big problem. Next slide, please. We asked participants how this was manifesting, so what was driving rates of fraud, waste and abuse. And one of the headline figures that we had back was that a lot of the time this was provider driven rather than being policyholder driven. So lots to do with provider behavior, things like induced demand and over servicing of clients. So you can see the breakdown here. And just a heads up, we're doing a publication and a separate webinar on this later in the year with ADB. So you will get access to all of this data. I know it's a lot to take in today. Next slide, please. And just the final slide that I want to share before passing over to Konark. When we asked individuals about the types of structured data they were collecting through their claims activity, what was really telling is that there were some very big gaps in terms of what was being collected, which perhaps limited their ability to detect, let alone manage fraud. So for example, information on a diagnosis code or a diagnosis treatment pathway was often not available. And without these kind of fundamental building blocks, actually doing some of these analytics becomes problematic. But I'm going to hand over to Konark now, who's going to take you through some of the technologies that could be employed in order to perhaps look at how countries can make progress in terms of this major issue. Thank you.
Yeah, thank you, Thalia. Yeah, so fraud, waste and abuse, it's not a new topic for healthcare and insurance industry. It's been there for long. And traditionally, the fraud management is taken as an exercise where you do more on the detection basis, like patient visits the hospital, they generate the bill, then it's given to the claims department, and then they start the investigation. And sometimes it's already too late for them to take any action. And most of the time, especially in public health, the Ministry of Health and related bodies have limited manpower as well. So amount of data, amount of claims which come out are huge, and there was not enough support to our manpower to tackle this particular topic. But over the last few years, things have changed. And thanks to the increase in data processing power, we can do things which were near impossible like 5-10 years back. And now, especially in this field, governments and companies, insurers, they're leveraging such technologies. Few of them are listed here to fight fraud detection, prevention, etc. And now, as the maturity grows, we are moving from fraud detection to prediction to prevention. So even before it's happening, we have to act in order to reduce the burden on the healthcare system with that. And to give you a few examples, especially, for example, on the detection side, now with the power of data analytics, machine learning, AI, and very recently Gen AI, we can identify such patterns. We can identify such anomalies, such behavior where there are fraudulent activities or waste happening, which can identify. And then when we support it with the predictive modelings, we can train these models. So as I mentioned earlier, like healthcare has huge amount of data, and this time we can use it for our advantage, that these predictive models can learn really fast and can identify such patterns. And in combination of machines or the technologies, well supplemented by medical experts, they can then look into such high probability cases to further deep dive and look into different fraud areas, be it from the healthcare provider side, be it from the patient, pharmacies, in terms of payments, etc. And along, as I said, when these technologies progress, they eventually can be used in the preventive ways as well. Tools can identify the frauds, the probability of frauds happening in a particular, for example, a treatment type or a particular facility or particular demographics. They can identify, and proactive actions can be taken around that. Also, in the similar space now, there are ways to help prevent such claims or even the frauds from happening. For example, blockchain technologies recently has been used to get the medical data transactions going. And with the blockchain, it's very difficult to tamper that data. So the data quality can be ensured. Similarly, in order to prevent such fraud right at the source, biometric authentication, serverless systems, these technologies have come in place where it can help prevent, say, identity fraud or completely false claims where the patient has not even visited the hospital. So governments are using such technology as well to prevent it right at the source. In terms of connectivity, all these technologies are now collected to, say, a claims analysis tool or a surveillance system or even a compliance system, making it an interconnected a web of technologies which have a common goal. And the idea is to prevent fraud, risk, and abuse from happening altogether. Next slide, please. And it's the same argument is well supported by the survey results as well, that data sits at center of all this. That you need to have, you need to collect data. You need to have a well-defined data input mechanism in place. Once you have a good quality data, then only all these technologies can help you. Similarly, you need effective data exchanges. And in order to, again, process all this, you first need to have your patient data, treatment data into electronic form. So electronic health systems come into play where you have EHR or electronic health records in place. So in summary, it's again justifying what we already understand, that data sits at the center. And we can see that in few use cases or examples from few countries where they are investing heavily on fraud, waste, and abuse management. So if you can go to next slide, we have a few examples from you. There's an example from Indonesia. So as you're aware that Indonesia is comprises of over 1,700 islands, and this with back it with over 280 million population, so fourth largest, fourth most populous country in the world. So when they implemented UHI, you can only imagine huge amount of roadblocks and issues they faced initially, and fraud being one of the major issues for them as well. And that's why Indonesia invested heavily on big data analytics and business intelligence software, with the main aim to detect claims, frauds, abuse from happening. And they are, though early in this journey, they have started to already see a good amount of dollar value saved from such tools. So they have used technology for, again, good usage, so that the more funding or more dollars are available for the patient who need it the most than getting into wasted into fraudulent activities and such abuse. So next slide, please. On the other side, as you are again aware that South Korea is more like ahead in terms of maturity of healthcare system, and they have also invested heavily in terms of rule-based or pattern-based identification using artificial intelligence and machine learning. They have deployed this software again for about 7 years now. They even included factors from which resulted due to COVID into their model as well, and they have received good results. The way it works, just to give you further details, is the tool or the identification tool identify high risk cases based on the patterns and behavior analysis and existing health data, and they pass it on to the medical experts. So medical experts now can concentrate on high risk cases where probability of fraud is high, and that's why it's better effective utilization of their time. And again, they have seen good results coming out of it, and it's a very good case study for other countries to follow as well. Yeah, next slide, please. One more example is from Philippines. So Philippines also has PhilHealth as a universal health insurance program, and they have also, being a large country with remote places, they have also had issues around fraud and falsified claims. And as they are very early in the journey, for them, it was very difficult to have data-based analytics in place. To tackle this particular issue, what they did was they invested more on biometric checks. So as I was mentioning, they have the idea or premise behind that is they can detect the fraud or abuse from happening at the source itself. So they have deployed, say, biometric softwares at the healthcare facilities itself, so that they can identify the patient more effectively. And again, the chances of identity fraud, etc., would be less. So another example of when you are not far ahead in terms of your data analytics journey, you don't have electronic health record in place, you can still do utilize technology to better fight fraud risk and abuse in that particular scenario. Yeah, so next slide, please. Yeah, so as to conclude, yes, technology can be used to fight fraud risk and abuse in a very effective way, and it can eventually save billions every year, which is currently being wasted and can effectively be utilized for better patient care just by detecting few key indicators, including technology into your key processes, identifying fraud, risk, abuse wherever possible, and then take mitigative action and eventually move far ahead in the journey where you can start detecting and then eventually preventing fraud. So yeah, that's where technology can effectively help. Thank you, everyone, for listening. I'll pass it on to our next speaker. Thank you.
Thank you, Thalia and Kunar, for an insightful session. So now to build upon, next session is on case studies to stimulate cross-learning on digital health financing. And for this, I would like to invite Dr. Santosh Moses, Principal Public Health, IQVIA. Over to you.
Thank you, Parul, and thank you, Talia and Konark, for setting the context. What we'll attempt to do in this session is to deep dive into more detailed case studies of 3 countries which we have shortlisted from a cohort of 25 case studies. Our attempt is to highlight these case studies so that they can promote innovation, reduce risks, guide policy formulation, and also increase the ripple effect of digital health financing initiatives globally. We embarked on a comprehensive global benchmarking exercise aimed to identify successful models incorporating digital innovations that have contributed to increasing efficiency and transparency of health financing systems worldwide. A board of experts from the Asian Development Bank and IQVIA was constituted for selecting these 3 top case studies, a run-through of which we will take you through country by country. We'll start with Estonia up in the Baltics. Estonia is regarded as a pioneer in its region, not just in Central Asia, but also in Eastern Europe, for digitalizing its healthcare delivery, e-health innovation, and cashless society. Notably, 99.9% of the prescriptions in the country are issued digitally, amounting to approximately about 10 million prescriptions annually, resulting in not just time savings, but also significant cost savings. But this has not been without challenges. While establishing a national health financing system for the country, Estonia's claim processing system encountered several issues related to administrative workload, processing errors, and delays. And these challenges, I'm sure all of us are aware, are not unique just to Estonia, but are common across many health systems across the world. Managing large volumes of claims requires significant human effort and resources, leading to inefficiencies and insurmountable delays. To address these challenges, Estonia embarked on its digital transformation journey by transitioning towards an electronic invoicing system, which is aligned with international e-invoicing systems globally. Through e-invoicing, Estonia has established clear organizational structures, streamlined processes, and fostered greater accountability. As we go deeper into Estonia's journey, let's move on to the specific interventions which they have undertaken and impact of these interventions on the health financing system. With the focus of the transformative impact of digital health financing and e-channels within the Estonian Health Insurance Fund, the e-system revolutionized claims processing, reduced administrative burdens, and created summary invoices for non-specific case payments. Digitalizing invoicing through streamlined e-channels introduced automated controls to ensure accuracy and compliance within established criteria. Estonia was able to facilitate the digitalization of their invoicing system by leveraging machine learning techniques, which Konark and Talia just explained. This facilitated automated claim verification and effective monitoring, which has become a hallmark and a benchmark for the other countries to follow suit. Additionally, Estonia has developed through Power BI a comprehensive dashboard, not just for pattern identification, but also for ratification of errors. Estonia's journey is a testament to the transformative power of machine learning and other digital tools in creating effective systems for change. We'll move on to our next country and right here in Southeast Asia. Indonesia is a country on a transformative journey in health financing. They have introduced what they're calling the mobile JKN system, which has been a game changer, not just in the country, but also in the Southeast Asia region. This mobile application has enhanced service delivery and user experience through a unified platform that provides access to health information and services. Indonesia, as all of us are aware, is a country with a large population of over 260 million people, and is on a path of becoming one of the world's most extensive single-payer social health insurance system. Historically, out-of-pocket expenditures and payments have dominated the healthcare financing, accounting for approximately 50% of health expenditures between 2002 and 2013. This highlighted a critical area for reform in the pursuit of universal health coverage. In response to the various challenges, which were delayed waiting times, burdensome administrative procedures, limited access to health information and services, and strained health service delivery, which is virtually a footfall of nearly 300,000 people every day, this impacted user satisfaction significantly. And to Indonesia's credit, the satisfaction indexes were tracked very, very closely. And the satisfaction indexes were in terms of unsatisfactory, were close to 78%. In response to the highlighted challenges, The JKN application was introduced in 2017, and this was a pioneering initiative that has consolidated all pre-existing insurance schemes into a single cohesive national platform. The application has been designed to simplify payments, facilitate membership data modifications, reduce patient time significantly, and provide information about health facilities and improve overall satisfaction for patients. Next slide, please. The mobile JKN application has revolutionized access to healthcare services, enhancing user experience significantly. The application offers a complete range of features, including registration and enrollment, access to medical services, PHC primary healthcare service provider selection, payment management, queue management, and a complete rehab program for settling outstanding dues in installments. Since its launch, the application has been used approximately by 3.5 million users, with majority of being from the private formal sector and the non-poor informal sector. The success of this program has influenced and boosted participation coverage to over 93% of Indonesia's 260 million population. This is very significant for a country of the size of Indonesia, and the application has been downloaded over 10 million times, with over 432,000 users actively utilizing the app as we speak. The impact of the application on the Indonesia's national health insurance system has been significant. Following its introduction, there have been notable improvements across various matrices, such as increased user satisfaction and a significant reduction in the number of users visiting the office. Like I said earlier, there were about 300,000 daily visitors to the office, and this has reduced significantly. The mobile application represents a significant milestone in Indonesia's journey towards universal health coverage, and this is a great model and a case study for other countries in the region and globally to be adopted. We'll move on to our last case study and third country in our segment, which is the Republic of Korea. A lot of us have heard, the tremendous strides South Korea has made in terms of universal health coverage. It is a nation that stands as a paradigm of rapid industrialization and evolution in healthcare, has achieved universal coverage in less than 12 years of inception, and it has swiftly transitioned from a private healthcare insurance model to a mandatory national coverage, highlighting the nation's commitment to modernizing and strengthening its healthcare system. The NHIS encountered significant hurdles initially, such as providers facing mounting paperwork, leading to increased workload associated with benefit claims review, the need for rigorous quality assessments to evaluate providers' performance, patient outcomes, fraudulent practices, which was also a significant concern. Another significant challenge was also the efficient allocation of healthcare resources that involves making decisions about where and how to use resources. This requires careful planning, prioritization, and management to ensure resource utilization is being done appropriately. In response to these plethora of challenges, Health Insurance Review and Assessment Service, or HIRA, adopted an advanced information and communication technology framework, or an ICT framework. This framework has been integral to Korea's healthcare landscape, connecting healthcare facilities and pharmacies nationwide. It serves as the nucleus or hub for claims processing and reimbursements, signifying a major stride in managing benefit claim, quality assessment, and resource allocation. Over the years, HIRA has progressively broadened the scope of this interconnected infrastructure, and its adaptability has been instrumental in Korea's response to health emergencies and outbreaks. There are multiple components within the HIRA's comprehensive ICT system. The first one being the Healthcare Data Acquisition System, or HDAS, which is one of the cornerstones of HIRA's ICT system and has revolutionized data collection, managing information concerning healthcare services, and resource status of providers. The system has achieved notable success, with providers seamlessly submitting over 1.5 billion claims annually directly to HIRA, which has saved a lot of time and reduced high administrative expenses. The second component is the Health Data Review and Assessment System, or the HRAS, serves as a critical framework for reviewing claims and assessing quality of care. It plays a crucial role in determining reimbursement amounts while effectively preventing excessive spending and promoting appropriate levels of medical billing and quality enhancement. The HRAS system has been instrumental in saving an estimated $1.25 billion annually. The third component is the Pharmaceutical Information System, which optimizes drug distribution by assigning standard codes to individual pharmaceutical products. This simplifies tracking and tracing activities within the market. The repository of health data, the healthcare big data system, or the HBIG, generates and disseminates precise and uniform statistics derived from big data accumulated during operations of the National Health Insurance System. The provider integrated profiling system significantly aids in reallocation of health resources through its effective monitoring of health resource status. This monitors the status of 96,253 providers and analyzes pertinent data indicators. Lastly, the drug utilization review system promotes safe drug utilization and offers real-time information aiding in the prevention of infectious disease transmission. Altogether, HERA's ICT system has been instrumental in streamlining benefit claim review, assessment, and resource management, thereby ultimately improving patient care outcomes. HERA has shown its unwavering commitment towards crisis response and management by devising effective strategies to address public health emergencies, including the COVID-19 pandemic, and all of us are aware of how the Republic of Korea managed the COVID-19 pandemic. The implementation of the HERA ICT system has brought significant benefits, including streamlined benefit claims review, enhanced quality assessment, efficient healthcare resource utilization, seamless healthcare service delivery, and adept response to emergent public health emergencies. As we conclude, let's reflect on the transformative impact of digital technologies in enhancing health finance system as demonstrated by Estonia, Indonesia, and South Korea. These countries give us a tremendous model and impact as to how digital health financing and the innovation in technology and applicability of machine learning and artificial intelligence can revolutionize the progress towards universal health coverage and strengthening health financing reforms in these countries. They demonstrate with strategic investment and adoption of digital solutions, health systems may significantly improve not just operational efficiencies, but ultimately patient experiences and achieving overall health outcomes. Thank you. I'll pass it back to the moderator. Thank you everyone for joining the call.
Thank you, Dr. Santosh, for thought-provoking session. I request the participants to kindly share questions in the chat box. So now, before inviting our next speaker, I would like to bring a brief note on our hackathon challenge that was conducted as part of this TA. ADB, IQVIA, and Dalberg collaborated to conduct an exciting digital health financing innovation challenge. Goal was to find two promising solutions that can transform health financing systems using cutting-edge digital technologies. Therefore, participants were invited from across the globe, and they were asked to submit applications targeting predefined specific problem statements. After careful review, we narrowed down the pool to almost top 11 contenders. These finalists then underwent evaluation by a panel of experts. As an outcome of the hackathon challenge, two minimum viable products were identified that harness the power of artificial intelligence, machine learning, deep tech, and advanced data analytics. These solutions hold immense potential for reshaping the future of health financing. Therefore, I now invite Dr. Pranay from Artivatic, which is one of the winners from our hackathon challenge.
Hello, good afternoon, everyone. Thank you for this opportunity to represent Artivatic and the solutions what we offer. Next slide, please. So just to start with, I'll give you a brief introduction of Artivatic. Artivatic is an AI and ML based API infrastructure, which is a data-driven platform, which offers variety of solutions to help in the digital transformation, new age solution building, as well as to make up the data-driven decisions. We were founded way back in 2018, and since then we have expanded our team to more than 300 people located in 4 different locations in India. We are based out of Gurgaon, Bangalore, Mumbai, and Indore. All our solutions help in variety of challenges addressed. For example, we help in smart policy administration and product design, as well as rule configuration. Some of our solutions help in the smart accelerated underwriting, risk assessment, and fraud detection. Now, out of the different speakers who were here, some of them mentioned the inefficiencies in the healthcare system. Our solutions are designed to address those. For example, simple document processing and extraction is one of our APIs, which can be used to address these challenges. There is also a digital onboarding of the customer and agent, sales enablement, communication, sales engagement platforms. We have a solution which offers the claims auto adjudication, decision automation, as well as claim settlement, which all happens digitally. There is a particular NeoHealth application which is specifically designed with the patient in mind, which has all the health locker, which is UHI, Unified Health Identifier at a core, and it helps in variety of a claim adjudication, underwriting, as well as having solutions around the health and chronic disease management. We also provide solutions in the provider platform and network communication, commission management, payment and dashboarding. APIs and data layer is something which we are very good at, and we offer more than 700 APIs which can offer full stack solutions to integrate with variety of ecosystems, government databases, data partners, cloud partners, and distributions. Next slide, please. So in this particular slide, what you are seeing is variety of benefits and advantages which our solutions offer. Some of these are mentioned here. Some of these are, say, new business and artificial intelligence through the underwriting and the pricing models. We also have product and product designing platform where we can design a particular product based on customization of a retail patient as well as a group policy if we need to design that. There is an AI claim processing model which helps in the auto adjudication process, which reduces variety of inefficiencies in the operational part, helping the claim auto adjudication running very fast all throughout the time. So it can do the auto adjudication anywhere between 2 to 5 minutes for the claims which are completely digitized, as well as helping the reimbursement of the claims as well. Now, solutions also help in the post-discharge support as well as chronic patient management when it comes to the chronic disease or lifestyle-related disorders. There are other benefits such as instant policy issuance, pre-policy issuance verification, where the identity as well as the other type of frauds can be addressed. Variety of analytics and dashboarding is done, which helps not only just the patient but also the payer to see how the entire claim processing is happening, how the entire say policy is utilized over the period of time. It has a timelines in it. It gives the entire analytics at the fingertips. It has a disease management as well as OPD benefit solutions, which helps in not only the inpatient but also the outpatient service modeling as well as the financial aspect of the entire claim processing. Alternative risk assessment is one of our strengths, which helps in basically underwrite a particular policy in a short amount of time by bringing in variety of insights, not just from the health of the patient, the data which is available on the health locker of the patient, but also from the smart wearable devices, as well as variety of a patient related documentation such as pharmacy documents as lab documents as well. We also have documents and data storage platforms such as NeoHealth, which helps the patient to carry their electronic health records anywhere and manage the entire consent to whom it should be participated or given access to and get the benefit out of it. Next slide, please. Here, what we are seeing is the major use cases where I'm focusing currently on the digitization across the insurance value chain, as well as spotting and preventing the fraud in the healthcare system. When it comes to the digitization, there are solutions which helps in the simplifying lengthy and complex insurance application forms to make it more streamlined application, user-friendly comparisons of variety of policy documents, policy products, so that end consumer can see different products at the same platform and compare and see what are the advantages of one over the other and easily finance that and pay for it on the same application. There is an efficient and easy claim submission process. This helps in the entire end-to-end claim processing through a single digital journey through an application. So digitization across the insurance value chain is addressed by a variety of our solutions. The second addressable use case is for the fraud. Now, in the fraud, there are a variety of solutions. So it could be a hard fraud or a soft fraud. When it comes to the hard fraud, such as impersonation of a person who actually is pretending to be someone else. That is relatively rare, but also there are solutions which can detect that. For example, identity verification part is also present. One of the APIs can detect the identity of a person. Also phantom billing, which are considered as a soft fraud, and fraud prevention modules where overbilling, overcoding, all those can be easily identified, and that helps in addressing the fraud in the healthcare model. Next slide, please. So in this particular slide, this gives the overall solutions what we offer to address the demand and the supply end of the health financing part. So when it comes to the demand part, the end consumer would demand variety of requirements. So they may have the need for customized product. They would have paperless and self-assisted buying journey as one of their needs. All these are addressed through 5 of our solutions. One is mentioned as a Neo Health as well as Neo Sales. These are 2 of our end consumer demand-based application. This helps in basically addressing the need-based product as well as the user-friendly price comparison where the person can compare and buy one product over the other. It also has some of the solutions which helps in the entire easy claim submission portal as well as policy management. There is a portal where a post-discharge entire care can be managed through the Neo Health. Neo Sales, on the other hand, also helps the end consumer in the form that insurer would require some of these low-cost products to be displayed for the end consumer to be utilized, and Neo Sales helps in that part. Artivatic at the digital health tech platform has the inputs from the government as well as regulatory framework. We have a tie-ups with variety of providers and partners in the ecosystem. And by this, we address both the demand and the supply side. The supply side area, we address the insurers or the payers supply requirement through 4 of our solutions, which are the products which helps in the product design and the rule configuration. So customized rule configuration can be done based on the different geographies, different customers, as well as a group designing of a particular product. OSIS is an alternate underwriting as well as risk platform. This particularly helps in having the data backed up risk assessment for not only just the health, but also the life part of the person. So the entire underwriting and alternate underwriting risk assessment is done here. We use data which are geographically present, for example, sanitation data, AQI index data, Poland's data, to figure out what kind of a risk a person would have over the period of time. This also helps in not only the underwriting of that part, but also the disease prediction over the period of time. There are solutions to help the payer as well as provider, the hospital as well as the insurer, I mean. So Alfred has a claim automation platform. It is for both the insurer as well as provider, where variety of ICD coding, CPT coding happens in the Alfred, which helps in reducing the inefficiency by addressing variety of claim processing timelines. It increases the claim processing, helps in variety of mismatching of a particular ICD code, reducing the fraud in the entire healthcare efficiency model. There are solutions which helps in the insights for the fraud. For example, over the period of time, if you see overbilling in certain areas, there are solutions which will detect that particular slide. So in the end, just to conclude, all our solutions are revolving around the operational efficiency, the clinical and behavioral efficiency improvement, and these 5 solutions address a majority of those problems. That's pretty much. Thank you for the opportunity. Back to you, moderator.
Thank you, Dr. Pranay. I now invite Mr. Ivan from Ray, which was also one of our winners from Hackathon Challenge. Over to you, Mr. Ivan.
Thank you so much. So hi, everyone. So this is Ray. We are an Indonesian first digital integrated health and life protection platform. So we are a health and insurtech platform at the same time. We are the only platform right now in Indonesia that is registered both as an insurtech platform with our financial regulator, but at the same time as a digital health provider in our Ministry of Health. So we are still standing in the intersection between healthcare and insurance. And basically the task that Ray is trying to deliver is to redefine health and life protection. Next slide. So before I share about the products, right? Basically, it is very important to see what problems we have right now. And I think a lot of people saying that the problems of health and life protection is people saying that, okay, like health protection, health insurance is very complicated and expensive and blah, blah, blah. But there's only one root cause that's sometimes overlooked by people. And that root cause is the healthcare and insurance disconnect. So that disconnection or that disintegration between healthcare and insurance making a lot of problems that we see in everyday life, right? Number one, definitely insurance abuse by healthcare system, FWA, that we discussed since the earlier of the sessions. And then when the insurance or the payers getting abused by the healthcare systems, if they want to create a protection product, and they want to protect themselves, of course, the product becoming complex and the pricing cannot be optimized. And most importantly, people feeling that the healthcare delivered is very transactional and reactive rather than focusing on the well-being itself. So then when we see to the impact, the impact of these problems is happening both ends, right? On the demand side, people don't like to buy insurance, people don't like to get health protection. And for example, taking an example in Indonesia, penetration is lower than 3% forever. And then also from the supply side, the insurers and the payers, they're not sustainably supporting health protection products. So this is signified by the claim loss that is really high. In Indonesia, for example, the average is above 90%. In the past few weeks, I discussed with CEOs of insurance, some of them already passing 110, 120%. So that's technically, like putting things together, this is an industry issue that happens on both demand and supply side. So when we come into the market, we have a new approach. Basically, let's redesign everything. Let's redefine the health protection through a new approach and make a new generation of health protection that is basically, next slide, please. Basically, we are completely integrating healthcare and insurance since day one. We put everything in one platform. We deliver from prevention to protection as one experience because we believe that we cannot solve the insurance and payer issues without being deep working in the healthcare side, and we cannot integrate with the payers. We cannot solve the healthcare as well. We cannot deliver the best healthcare if we don't include the payer inside of the equation. So how's the product looking like? Next slide. So this is how the product is looking like for the members. So basically, we sell these products to individuals and families and also for companies, for their employees. But the product, think of it like a subscription. Like think of it like a Netflix or Spotify. But when you do subscribe Netflix, it's for your entertainment. You subscribe, pay monthly or yearly, and then you have access to watch all the movies. In Ray, think of it as a subscription, but for your healthcare. One thing that is fundamentally different between Ray and typical conventional insurance is something in the middle there, which is personalized health records, right? So if conventional insurance basically centering around policy admin system, policy ID, document number, and stuff, we want to center this around you as a person, right? So we have a personalized health records that takes care of all the data, and then we build all the features around it, right? So all of these features, end-to-end healthcare, people can use it when they're healthy, starting with, people talking with the nutritionist one-on-one, get a meal plan, mental wellness, activity trackers, health diaries, get rewards. And also when people are sick, starting with talking with the doctors, primary care, getting prescription delivered. When they go to offline as well, we basically working on the claim. So the claim is very instant, digital, no need hard copy, 100%. We don't believe in hospital network. Everything is cashless everywhere. We work disrupting the payment system. Also, we have this care team that will walk and talk with the members. Along the way, we want to make conversation 24/7 and navigating the members throughout the complicated world of healthcare. So this is the approach that we do, prevention to protection, integrated, and the beauty of it is all these features are accessible for these members without anything being charged extra because insurance is already embedded inside of the subscription to pay for everything. The beauty of this is definitely a lot of advantages that are being unlocked. Number one is that we can optimize the healthcare spending. Number two, the process is smooth because we are the healthcare and at the same time the payer. So people just interact with us, accessing the healthcare, just speak with us. We'll make sure everything is smooth from the booking to admission to discharge. And then we are also at every medical data and interaction, so we can detect fraud better. And then we also, can predict and prevent chronic disease. All of the things that we do is active health management. It's not, just a gimmick for the members. Next. This is what we've been able to deliver in the market. If you imagine, we've been able to, in Indonesia, deliver a health coverage that not only holistic for people to use when they are both healthy and they are sick, but also unorthodox. We have crazy rules. For example, our products, our membership of Ray is outpatient first. So that means people can buy outpatient product on a standalone basis. If conventional insurance, they are running away from outpatient, they just want to take care of the inpatient and critical illness and life. We want to take care of the people. So we start with outpatient and people can get outpatient first. The pricing is 1/3 of conventional insurance because we eliminate agents. And that happens because we make the product easier to perceive by people. It's a simpler product. Suddenly, it's just healthcare for the people and health solution. But also, we optimize the healthcare spending and also the claim loss. So if in Indonesia, the average claim loss is above 90%, we are now at the range of 40%. And we can do this because we do the healthcare engagement, our primary care, our care team, we detect fraud better, and then we do preventive. And this is what we've been able to achieve so far. Next. The product have been launched in July 2022, right? So it's more than 1.5 years. Last year, which is 2023, was our second year. We closed the year collecting $1 million of annual membership revenue. Out of the total paying members that we got, more than 80% are still active and being paid and persisting in the platform. So that means people enjoying the process of healthcare inside of the platform. And then lastly, next slide. This is also one thing that is exciting for us to see is who becomes the member of Ray. And unlike conventional insurance that typically centering around big cities because of the way the product's being set up and the distributions using agents, our product of Ray, suddenly, we simplify everything into healthcare solutions, both when people are healthy and sick, and we can relate to more people. Everything is digital first. So we already covering almost 100% of Indonesia. We have members coming from lower tier areas and people that never purchased insurance before. So basically, this is showing that our approach actually can relate to more people and enlarge the pie and also tap the untapped segments. So that's basically what we deliver to Indonesia. Thank you so much.
Thank you, Dr. Pranay and Mr. Ivan, for an insightful session and driving us through your respective solutions. Next in line is panel discussion, and I invite Dr. J, Health Specialist, Asian Development Bank, as the moderator for the session. Over to you, Dr. J.
Yes, thank you very much, Paro, and thank you to all the speakers for the inspiring presentations. And among the audience, if any of the content has sparked your interest and you wish to partner with us or participate in the initiative, please don't hesitate to approach us. Now we'll move to the panel discussion in the theme of Roadmap for Digitization within Health Financing Schemes in Asia and Pacific. I'm Jae-Kyun Kim. I'm a health specialist at ADB, co-leading the TA with Akihito. And we are thrilled to have a distinguished panel of experts here who will share their insights and experiences from various countries. Now, let me introduce our esteemed panel members. First of all, we have Dr. Enamul Haq, Director General of the Health Economics Unit from Bangladesh. Thank you very much, sir, for joining. Mr. Samber Karazan, Advisor at the Ministry of Health in Armenia. Thank you very much for your time. Mr. Serenocir Biambatuga, Senior Officer in charge of Digital Health Transformation at the Ministry of Health in Mongolia. Thank you so much for coming. And as a panel member, we also have Yesu and Nishan Jain from our own ADB, health specialists. So let's dive into our discussions with a universal question for Dr. Enamul, Mr. Sambel, and Mr. Serenocir first. So I would like to ask that how have digital technologies in health financing systems advanced universal health coverage in your country? And what do you perceive as the most significant barrier to its progress? I would like to first call on Dr. Enamul to the stage. Thank you.
Thanks. Thanks the presenter, speaker, and others who have joined through the online version. Thank Jay for your nice question. Actually, integration of digital technologies within the health system has been instrumental in advancing the universal health coverage. We all know it. Definitely, it will foster the improvement in accessibility, efficiency, and accountability. Government of Bangladesh has a place, and we have a roadmap to develop Bangladesh. Not only Bangladesh, but our Honorable Prime Minister has declared to make it a smart Bangladesh by 2041. It will anchor our unwavering commitment to achieve the universal health coverage as well. We have taken some initiative regarding the financial reform that has been initiated by the Ministry of Finance, and we call it the Public Financial Management Reform Initiative. And through this reform initiative, we have introduced a big platform that we call IBAS, Integrated Budget and Accounting System. It's a big software. Through this software, we prepare our budget, we distribute the budget to the field offices, and we release the fund, reappropriation, online submission of bills and payments, and other thing has been processed through the electronic fund transfer system. And we also issue the check and payment and other things through this IBAS software. It's a big software, and all the offices, government offices, presently they are using this software. And to tracking the development project, the Ministry of Planning in Bangladesh has recently introduced a software that we call ADP Management Software, Annual Development Program Management Software. And through this software, usually we are tracking and monitoring the physical and financial project progress of the development projects. However, government has a commitment to reduce the use of paper. We are also using e-Noti or D-Noti. Probably you are not well conversant with the D-Noti, digital file management system in the government services as well. We have also introduced the electronic government procurement system that we call EGP since 2000. So it is these are some of the example of going towards the digitalization of healthcare financing. And we have also introduced centrally, we have also introduced 10-digit national unique ID system through our civil registration and vital strategy secretariat, and it will definitely be a milestone. In case of Bangladesh, actually, we know still the financing system is supply side financing. It is not demand side financing. You have shown some of the examples of national health insurance or health insurance system, some of the countries in Asia and the Pacific region. But in our country, it is supply side financing. But definitely we are using IBAS software. We are financing the health facilities and the health institutes. Even though each and every up to the grassroots level, we are financing using the IBAS system. Probably you are well aware that we have community clinic at the doorstep of each 6,000 population of the country, and more than 14,000 community clinics are now functioning to render the primary healthcare services to the poor, to the rural people of the country. We have a robust health analytics platform like DHIS2 dashboard, District Health Information System, second version dashboard, and it's a real-time information portals. The platform empowers stakeholders with valuable insight, facilitating informed decision-making and efficient resource allocation, thus optimizing healthcare delivery. We have also a plan to make the automation of the hospitals and electronic referral system from primary healthcare center to the upper healthcare centers. Currently, there is no law, definitely, for protection of privacy and confidentiality of health data in Bangladesh. And we also acknowledge and envision that there is a lot of scope to enhance our digital health financing system. So our focus is on realizing an automated claims management system. We are using, as some of you know, that we are implementing or piloting a small program that we call Social Health Protection Scheme for the poor people in some of the in 7 districts and 2 city corporations of Bangladesh. So we need, we feel the need of the automated claim management system to further strengthen our reimbursement process and enhance our anti-fraud mechanism in those systems. And in the claim management system, we would entail engagement of artificial intelligence and machine learning, and some best practices also today shared by some of our scholars from different countries, starting from Estonia, Armenia, Korea, Indonesia, and some other, even from the Philippines. So we need to introduce some of the best system to check the fraud and other activities in the demand side financing system in the healthcare. These are the issues definitely to share with you. Thank you.
Oh, yes. Thank you very much,
That's it.
TG, for sharing the good practices from Bangladesh. The Smart Bangladesh initiative sounds very promising, and a lot of great works are going on. And ADB is glad to be partnering on this road to digitization in Bangladesh. Thank you, TG. So over to you, Mr. Sambel.
Thank you. Thank you very much. I will share the experience of the Armenia in the implementation of health information system and regarding the financial mechanism changes. In Armenia, we starting implementation of the healthcare information system with the parallel of the health financing system reform, which is started by the end of 90s. The main goal of information systems, we know it is gives us the opportunity to be more accountable for the public, because we have collected data, statistical data, data about the reimbursement, how much is spent in the health care system, for which purposes these expenses did, what is the cost of hospital case, or what is the cost of outpatient visit. And when you have this data and data collection system, you have the opportunity to make decisions to implement new programs, to justify them for the society, for the government agencies, parliament, etc. And of course, society sees that the taxes they pay are directed to this or that healthcare programs, and within this reimbursed some kind of services which was provided to them. And we can ensure that society participation in the decision-making process is very significant in this kind. And I can remember that when we are starting implementation of this system, we're starting with the paper-based reports, which are filled by the doctors, and all these reports were provided by the persons from the medical institutions and in the governmental agency, which is called State Health Agency. The other persons are starting to scan all these papers, and I remember that in the hospitals, doctors called these papers like black papers because it is very, very difficult and complicated to fill all these parts and do not have any mistakes, because otherwise the scanner can't understand what is there, and they can lose their cases and they can't be reimbursed, for example. After this process, we started implementation of the system when in hospitals, in primary healthcare facilities, the operators can feed directly into the system the information about the cases, about their some history, medical history, etc. And after it, they send this information, send these databases to central or regional levels of the government agency, and input it in the database, overall database, and we get some reports and information. And this process, of course, is very, very difficult, and it is very, very useful for, of course, for decision makers. But sometimes when you have the results, final results, and you can evaluate and assess the information you get and data you get from the different parts of healthcare system, it is, of course, very, very approachable and very useful for the system. And I can mention some obstacles that are overcome, of course, over time. For example, I already say that when we starting the implementation, the internet service in Armenia was very weak. So we created local systems, and the data was transferred via dial-up. Perhaps many of the participants in the webinar can have the similar situation, and can had similar situation in their country. Now we already have web-based systems that can exchange data online within the other systems, and even without the intervention of any entity, any person. We have local information systems which owned by medical facilities, and these systems already integrated to the health information system of the Ministry of Health. We have applications for prescriptions of the medicine, and for ambulatory visit registration also, we use these applications. But in my opinion, the biggest obstacle is people's desire to be more accountable, more transparent, more controllable. And to overcome this, I think that it's very important, and it's necessary to create systems that will show over time how they change the lives, the behaviors of users, and how they become more applicable, and they can use them, and they can be more applicable for everyone. Thank you.
Yes, thank you very much, Mr. Sambel, for sharing the situation of Armenia, the current work being done, and the obstacles as well. I think it's not just Armenia that we are feeling on those obstacles. It's applicable for other member countries as well. So we should all think together to how we can overcome those obstacles together. Thank you very much. Now, I would like to invite Mr. Seren Ochir from Mongolia, please. Sorry, I think you're on mute. Could you unmute yourself? Perhaps I think Mr. Seren is going through a technical problem. So in that case, I would like to invite our other two panelists from ADB. So we will be having a slightly different question, but aligned to the previous question we had. So the question we want to ask to Yeshu and Nishant is, what are the key barriers hindering the adoption and scale up of digital health financing solutions? And how could the Asian Development Bank support and partner with our developing member countries to address them? So I would like to first invite Yesu. Thank you.
Thank you, Jay. Thanks a lot, and really a pleasure to be here today. I'm really glad to see that Indonesia, the country that I mainly worked on right now, appeared in many of the presentations, indicating that this is a country that's proactively adopting health digitalization to improve health financing and health services. So we heard about the BPJS Kesehatan's efforts to apply DFRADA business intelligence software to detect the fraud for hospital service, and also application of online pharmacy system to improve billing and drug delivery efficiency, resulting in 25 to 30% gains in operational efficiency. That's very impressive. We heard that the JKM mobile application is now providing a one-stop interface for healthcare and billing services that enhanced user experience, eased the claiming process, and also promoted access to health information, provider information, etc. So we also see raised innovation with private insurance market, which is very, very interesting. So these examples really show that digitization has the potential to change the interaction among patients, providers, and insurers, and really help the development of the health insurance market. It can be led by a national health insurance, or it can be participated by private insurers to provide that necessary financial protection to everyone. So we would love to see these innovations be scaled up and continuously be expanded and improved. I would just offer some observations from my side as the barriers to this process, based on the key stakeholders that we have in this landscape. So first is on the provider side. So we know that in countries like Indonesia, developing countries, there is a huge regional differences and a huge capacity differences in terms of the digital knowledge at the central level compared with at the local level. However, in order to maximize the digital system, we need the providers on the ground and all the facilities and health workers to be able to integrate themselves and report the data about their health services into the digital system. So limited human resource were knowledgeable about digital solutions at the local level and lower level facilities is a critical barrier, and nurturing this workforce is critical for the adoption and scale up of the digital solutions to health financing. Second is on the user side. I think one of the presentation mentioned that 10 million people have signed up and downloaded and signed up the JKM mobile application. So that's 10 million out of the nearly 270 million enrollees of JKN. And I would expect that majority of those users will come from the more developed major cities and higher educated population. So how can we improve the adoption to digital health solutions in the general population and improve that equity to access to these digital solutions? I think it's very important to fulfill its maximum potential. Finally, I think on the role of the insurance administrator, so I think insurance administrator like BPJS Kesehatan now has an expanded role, not only to manage the balance of their funding, but also they face the challenge of utilizing the enormous data that they can get from the digital health system to really provide guidance and incentives through their payment mechanisms to influence the behavior of health providers. So healthcare market is really a very interesting market. There's, the problems of information asymmetry and provider-induced demand, etc. So all of these problems may be helped with better data analytics and more transparent insight into the care provision process. But this really requires a mindset change of the insurance fund administrators. I think companies like Ray would have that target from the very beginning, whereas for national health funds, sometimes they need to be assisted in doing that. And also that underlies a very important interaction between BPJS with the Ministry of Health, because as mentioned, their medical service tend to be very technical. So the improvement of standardized health services requires the technical support from the Ministry of Health in terms of determining the clinical pathways and appropriate care practice, etc. So how to turn these challenges into opportunities? In Indonesia, in December 2021, the ministry has launched the Digital Health Transformation Strategy Blueprint 2024, which identified 3 key priorities for digital health development in Indonesia. The first is to build an enterprise architecture of health technology to realize the digital integration of health information on an interoperable platform. This is to avoid the siloed approach and the fragmentation of data in the country. The second is to build the digital literacy of health workers to use digital health applications and to be able to conduct data analysis to inform service improvement. The third is to build the ecosystem of digital health by enhancing regulatory functions such as data protection, data standardization, and patient rights and privacy. It envisions the Indonesian Health Service, officially named the Satu Sehat, as the single platform for health data connectivity, analysis, and services to support and integrate various health applications in Indonesia. So ADB is now supporting Satu Sehat through our ongoing programs. Finally, I think Ray's case presents really a very interesting case where the private sector entrepreneurs can come in to compete with JKM. So this competition can be healthy for the health insurance market. ADB is also keen to explore engagement with the private sector in healthcare, including health insurance. So in closing, I really appreciate the presentations of the presenters today, and I look forward to further discussion with the audience. Thank you.
Yes, thank you very much, for sharing your insights, especially for Indonesia. Indeed, Indonesia has a lot of good examples like JKM Mobile and a lot of the works done by BPJS. So I think the other countries would be able to learn from Indonesia as well. And on the barriers that you mentioned on the digital literacy and the health workforce is really addressable to other countries as well. Now, I would like to invite Nishant. Nishant, please.
Thanks, Jay. And I hope that you are able to listen to me clearly. So thank you to all the presenters for excellent presentations. I think it was very enriching and learning. From the government side, DG from Bangladesh raised very interesting issues. And then from the private sector side, I think we saw some very interesting solutions. So when I look from the perspective of Indian government, for example, where we are very active right now from South Asia region ADB team, we see that in India, digital health is going on since quite some time. But the big push started in India on using information technology in health financing in 2008, when first time government of India launched a national health insurance scheme. That time it was called RSPY, where it was using a smart card and a digital platform to deliver health insurance scheme. That was the first big initiative. And this was the first time a biometric smart card with including fingerprint and everything was being issued to the poorest of the poor families. And the card was printed and issued in the field itself. So, so the family will come, they will get their pictures taken, get their biometric done, and they will print and issue the card and give it to them on the spot. And then they can go with that card, which will also store their entitlement of health insurance to any impaneled hospital and get treatment without any papers, because the card which was there was serving the purpose. So that was the first thing which started. But that time, one of the major limitation was that internet penetration was much lower in India. So you needed to have a chip-based card to work in offline model, because the online model was not so much easy to do everywhere. And second challenge was there was no digital platform nationally available. So you have to create your own platform from health insurance program, because there was no other option. But when India started working on their next national health insurance scheme, which was the reformed one in 2018, that time the internet penetration had improved much more. So when we designed, we started with a completely online IT platform, and digital solutions were completely online. So again, it was a very simple system for beneficiaries where if they are part of the list, then they can go to any of the impaneled hospital and just get their card made in the hospital itself. Now, it was simple from the perspective of the beneficiary, but the challenges was that again, there was no digital platform nationally. So again, health insurance program had to create its own digital platform. And that was a big issue, because for India, for example, there were 5 different programs, each of will give different ID to a hospital. So hospital may have 5 IDs given by different programs, and these IDs are not mapped to each other. Similarly, different program will give different ID to beneficiary. There may be no ID to a registry of pharmaceuticals, pharmacies, or the nurses. So there were a lot of challenges there. So that is why Indian government started a big program called Digital Mission, Ayushman Bharat Digital Mission, which was so I was working that time somewhere else, but I was involved in designing that program. And that time, this program started creating a background, started creating a whole system for digital health in India, where it talked about creating registries for doctors, for hospitals, for nurses, for pharmacies. At the same time, it started creating standards for interoperable health system, which means that different companies or the government can create different software, but they will talk to each other very easily because they will follow similar standards. APIs will be used to transfer data from one to another. And then it will become much easier. For example, right now, if a patient is part of the health insurance and getting the treatment, and if the same patient goes to a public hospital for something else which is not under health insurance, you cannot track that whether the same person has come there, because the IT systems were not talking to each other. But now with this creation of this whole IT backbone, this is something it makes it possible that you can do that. You can track patients, you can track patients can be given the power to decide who can access their data and not. So the digital health lockers facilities kind of thing can be provided. So a lot of these enablements has happened. Now the question here is, how about the adoption? And that is where I think the road hits the rubber. That because adoption, if it is weak, however good design you will do will be not working. So, and the challenges which we faced in adoption in India, when the digital health initiative started going to the field, one was that the inertia, people were used to working in certain way, and when a new thing come, it becomes a big challenge for them to change their mindset. So many times, even when you started the training and all for people, still they were finding ways to not do that, and then say, oh, this computer was not working today, so, or the internet was down today, so we had to do it in a different way, in a paper-based manner. So it takes time. It's not only technical training, it's also you have to continue the thing with their attitude and practices, and also trying to build incentives. So we were saying that if you were doing something through the online system, your payment will be faster, for example, vis-a-vis other system. So that kind of thing was tried somewhere. Somewhere it was mandatory that if you don't do online system, then you will not get the payment. Then it was kind of a carrot and a stick kind of thing which was there. So the training and the continuous training, and also how do you improve upon the people's inherent inertia on not using the technology, that was a big challenge in trying to influence the the persons, then also to have necessary budget available with the, especially with the public providers, because even if you give them computer, but maybe they don't have money for a software, or they don't have money to repair the computer. So sometimes these small things can also impact the adoption. So that was another problem which was faced, and the private sector was completely out. So in India per se, there is no health regulator as such. So the private sector can do what they want, but slowly also, and because also most of the hospital in private sector in India don't have an HMIS, health management information system, because they're smaller hospital. So, or they have some very rudimentary software. So again, how do you motivate them to have a better HMIS, have a digital health system which is interoperable? So that is where the challenge is, that how do you define the motivation for them, and how do you define levers which can encourage them? So that is where health financing comes, that if they're enrolled in the health insurance program, if they're impaneled, then they can actually be incentivized, they can be provided training, they can be linked. And that's how I think almost 30,000 hospitals which are part of the National Health Insurance Program have been trained, and they're using digital systems for already. But there are many more which are outside the health insurance program. And that's where I think the challenge is, that how do you bring them also into the digital health backbone? So that is one very important thing. And from the beneficiary perspective also, for them to start using these mobile apps, for them to start using various ways. For example, if a beneficiary wants to know where is the nearest hospital, what specialties are there, it's all available through the mobile app. But they need to not only download the app, but at the same time they need to also start using it in a simple way. So when we started the mobile app many years back, I think around 4 or 5 years back, that time it took some time, but I think within 2-3 years, as they started seeing simple things. For example, when you have the mobile app, if it is not very easy to use, even for somebody who is not very literate, then if they feel it's too complicated, then they will not use it. But if it is a very simple interface, and if there is any problem, there is a way to for them to get in touch with somebody to solve that problem, then it was much easier. So we linked a call center, toll-free call center, with the mobile app, that if there is a problem, they just click a button and it connects them to a call center, which then guides them. So these are the things which were used from the beneficiary perspective to help them in using and adapting these things. And even from the government functionaries, many times we talk about the hospitals and the beneficiary, but many times the government officers also are not very adept at using technology. And that's where I think to sensitize them about the importance and about how it will be simple. For example, we created very interesting dashboards, but the people who are supposed to use them were not using them. So we said, okay, fine. So we said your default setting on your browser is the moment you will open the browser, the dashboard will come first. So that, and then they said, okay, fine. Then they started looking at it, and then they got, okay, then they said, okay, can you add this indicator, that indicator, or can you change this? So it helped. So these are these very simple things which helps in the adoption, but it's a long way to go. As Ye was saying, in Indonesia, same in India. It's a huge country with huge variations in terms of the economic status, in terms of literacy, in terms of geographical areas, connectivity. So you have to have a tailored strategy. One size fits all cannot work in big countries. You have to have very tailored strategy which works at different places. And from ADB side, now we are trying to work very closely both at the national level and at the provincial or state level. So national level, you work on the guidelines, you work on the frameworks, you work on trying to create this incentive and disincentive structure. But at the provincial or state level, you actually work with the government on the implementation. So whichever health project we are doing, we are trying to have a strong component of digital health in that, so that, for example, right now I'm in a mission on a universal health coverage program in one of the provinces. And here we have a very strong digital component. And we are seeing that a lot of things you can learn from others, and you need not create everything de novo, right from scratch. You can build on what has been done already. So there are these solutions available, and the idea is to build on that rather than spending the energy and money on something creating from scratch. So ADB team is, yes, working very closely in India. And also, for example, in Bangladesh, we are trying to work with the government in trying to see how we can work with the health insurance program, which government is piloting. So these things we are working on. Stop here. Thank you very much for this opportunity. And thanks to all the panelists and the organizers.
Yes, thank you very much, Nishant, for sharing your real life experience on implementing these digital health solutions. That's so true. Even though we have like a fascinating system, like all well-planned projects, if the people in the ground doesn't use it, it's not getting used. So we'll need to really think about those things, and we have to make a sophisticated approach, maybe thinking in an anthropological way, even on how we can handle this kind of situations. Thank you so much, Nishant. And I see that Mr. Serin Ochir is back online. So, Mr. Serin, can I invite you, please?
Hello. Hello, everybody. Thank you for speakers and moderators. And I'm very happy to sharing experience about the Mongolian digital health financing. And firstly, Jay told the UHC, the key to achieving universal health coverage, the ways to make strategic the purchases and resulting in improved quality of care and services and financing efficiency increases. In the 2020, and the government enforced its efforts to establish the health insurance government organization as a single purchaser of health within a programmatic policy-based loan to strengthen health security and deepen supported by ADB. Since 2020, the HIGO implemented their own digital health insurance system. The system it works, and the totally about the Mongolia 800 health organizations that contracted by the HIGO. The health insurance system, the first service is discounted medicine. The writing e-prescription and the writing services to public and private sector organization within electronically, the e-claim. And e-claim, our Ministry of Health, the one requirement, your hospital information system is linked by the HIGO, the integrated. That's our requirement. And nowadays, around 800 health organizations exchanging data between the HIGO, e-claim, and claim review and claim monitoring and financing. Yeah. Nowadays, I'm sharing our the fraud detection model. Is possible? Okay. We are only two ways in the fraud detection. The one way is the system fraud detection model. The one way is citizen is fraud detection. System detection is not based in AI, just functionally. Citizen detection is if you get some hospital service and after you have SMS, you get some the hospital services, and if the patient is confirmed, that's okay. It's not confirmed that instigate their claim. There is a citizen control. The system it works on checking the fingerprint authentication biometric. We are using the biometric devices, the inpatient, and using their confirmed their fingerprints, and eClaim is checking it's confirmed by the fingerprints is checking. It's not confirmed. It's investigating again. Yes, that's our investigation model of the fraud detection. Yeah, thank you.
Oh, yes, thank you very much for sharing the examples of Mongolia. Indeed, HIGO has a very good system in interoperability linking with the hospitals and the government. And also thank you for sharing the examples of fraudulent. In fact, we had some more questions for the panelists, but in the interest of time, I would like to hear more, but I think we will have to go over to the Q&A session, since I've seeing a lot of interesting questions as well. And thank you very much for the audience for the inspiring questions. So I think we won't have time to address all of it, but I would like to highlight some of the questions. So the first question I would like to highlight is from Monica Sahai. The question is on I have a question. Technology clearly has some benefits for fraud, waste, and abuse, but where should countries start? And I think this will be a very good answer to be referenced by other countries as well. So I see Konark has already answered by the Q&A box, but if Konark, if you're willing to, could you share some more of your answers and insights, please?
Sure. Yeah. Thank you, Jay. Yeah, and thank you, Monica, for the question. So as I answered, right, the key to starting is start slow, start in the incremental step, and again, invest on data, like how you collect the data, how you manage the data. That's of paramount importance. And as starting point, set up the data standardization procedures in place, like how you collect data from hospitals, by clinics. You standardize that and start collecting data in more meaningful way. While doing this, you also interact with your hospitals, be it private, public, or clinic hospitals, to understand what systems, what procedures they have in place. So that, because they are the users, if they don't provide the data, you will not get the data. I'm sure many countries have seen that in action. In order to get that data, again, and invest in those procedures, have integrations with them, and have pilots, like start with few public hospitals, understand how the data is captured, especially in your medical claims data. Then invest in setting up your claims management or claims assessment tool. And while doing that, again, start small, that have, say, flags. Small flags, which even any user can take if there is a financial transition anomaly, if there is a fraudulent activity suspected, use those flags to get initial indicators. And then use small, like again, easy data analysis, descriptive analysis tools. Maybe start with Excel, as I mentioned, to get initial indicators where essentially the abuse is happening. And once your system starts becoming a little sophisticated, then invest in your data exchanges. How you exchange data between providers and with the, say, Ministry of Health and other departments. The more advanced stages would be once you set up those APIs in place where there is a real-time data interaction. You invest in that as well. And once you have these basic building blocks in place, then you can look into wider predictive fraud detection techniques, which we discussed about. Because you will be sitting on wealth of data, then it will be good time to invest in those predictive analytics, AI, ML based tools, etc. So it's as a summary: start slow, incremental steps. Start with basic data capturing methods, data foundation elements, data structure. Then go with case management on claims, then interconnected systems, and then advanced fraud detection tools in place. So it's incremental steps, and depends on which stage or which maturity the country is. They can take those measures.
Yes, thank you
Yeah,
very much,
thanks.
Konark. Yep. And the other question I would like to highlight is to Mr. Sambel. The question is, how do you manage data breach or protection in Armenia? It's very important in the terms of cybersecurity. So I would like to have some of your insights on this.
Yes, thank you for this question. In Armenia, we are regulated by the legislation. So we have some legislative databases in our legislation, the main legislation, which is regulated all healthcare system and interactions between parts of healthcare system. And there we have regulation on data access and criteria. So it is the main is that you need to have in legislation based who can get which kind of data can get and which kind of data they can have some access. And after this, of course, you need to expand all these regulations into the information system. And each user in the information system need to be access only on those data for which they're already registered. So it is based on their role in the system. So if he or she is the family doctor, so they can have access only for information about their touched population, their visits, their medical cards, and their referrals, e-prescriptions, etc. And if, for example, this person is referred to the hospital level, so the interaction, so the data about their provided services in the hospital can be also allowed to have for these family doctors for final overall control of these diseases, etc. So it is very important that when you logged into the system already will give you opportunity to have access only to those parts, to those modules of the system you have already registered based on legislation, based on your role, etc.
Thank you very much, Mr. Sambel, for your answer. I hope that would help the question, others in the question. Now, I would like to invite DG Dr. Enamo for a question. There's a question in how Bangladesh plans to automate claims in SSK. May I invite you, DG Enamo?
Yes. Thanks. Actually, what I have mentioned a few minutes back, that we have started piloting the social health protection scheme that is designed for the poor people of the country. And we started piloting it in 3 sub-districts, one district. And from last fiscal year, we have a plan to scale up these piloting activities in more districts, 6 more districts and 2 city corporations. We have a plan. Still, we are settling our claims that is being placed by the hospitals after treating the patient. We are settling it manually. We have a plan to introduce a UHC software, probably Universal Health Coverage software, we call it, and we have communicated with the A2I because you will happy to know that Bangladesh government has taken initiative to establish one ministry that we call ICT ministry. And there is a big project. Earlier it was called Access to Information. Now it is called Aspire to Innovate, A2I project. And we have signed an MAU with the A2I to make the claim process in an automatic system that you have shared so many presentations from a different part of the world. So we have signed the MAU and with the A2I, and they have extended their cooperation to support us to develop a good software, taking the best practices, considering the best practices worldwide that is now prevailing. And definitely we have a plan to introduce this software to make the claim processing as well as fraud checking in a good and in a that is in a computerized or an automatic, semi-automatic manner. So we have a plan to introduce it soon, and as well as you know, probably in Bangladesh we are implementing the sector program, a good umbrella program in the health sector. And in the upcoming 5th sector program, we have some specific operational plans that is called health management and information system, and some other activities in the operational plans to make it more automation and make it more citizen friendly as well as provider friendly, healthcare provider friendly. So we have a plan, and we will implement it from the 5th sector program that will be started from the July of this year. Thank you.
Oh, yes. Thank you very much, DG, for sharing the plans of Bangladesh. I really hope that it goes implemented well so it can benefit the population of Bangladesh. I would really like to address more questions, but unfortunately, we ran out of time. So I would like to invite Dr. Vasuntara, Senior Health Specialist in ADB as a OIC for Director Health, for closing remarks. Over to you, Vas. Thank you.
Hello, good morning, good afternoon, all the participants. On behalf of the health sector team and the Human and Social Development and TA 9967 team, we really want to thank you for being part of our 2-hour journey. And this is really a great in-depth exploration of the digital health financing in Asia Pacific region. In today's discussion, it really showed examples of innovative financing, including the challenges and actually practical example and government insight all the way from the Central Western Asia to South and South Asia. So this unique experience very well fit into our ADB Health Sector Directional Guide 2030, in which we are committed to support our developing member countries in harnessing the example of this transformative power of digital health financing. But in doing so, we not only work with governments, but as you can see from today, it's also with development partners, or new innovative firms, and also the stakeholders that can actually bring about this investment and sustainable development. As we part with today, this is the very beginning of the discussion. And with this shared vision, we hope that to actually explore further in terms of various additional case studies, the possible cross-learning, especially on the digital health and financing, and also come up with the digital solutions for our health and financing scheme in Asia and Pacific overall. Lastly, ADB would like to thank our moderators, speakers, and all the organizing team for this comprehensive and smooth organization of this virtual event. So we look forward to continuing these contributions and partnership, and really in building toward resilient but also equitable health systems that leave no one behind. So with that, we really appreciate everyone's participation, and have a good day. Thank you.
Okay, thank you very much, everyone.
Thank you very much, everyone.
Thank you.
Thank you. Thank you. Bye.
Bye-bye.
Thank you. Bye-bye.
Thank you, everyone. Cheers. Bye-bye.